neuromas, meningiomas, chordomas, as well as other complex brain tumor. He's also expert in treatment of brain aneurysms, arteriovenous malformations, and performance of bypass procedures. He's based at Harborview Medical Center here at University of Washington, and currently he's a professor and vice chair of the Department of Neurological Surgery. In addition, he's the past president of the prestigious North American Skull-Based Society, and also the prestigious North American, World Federation of Skull-Based Society, as well as Washington State Association of Neurological Surgeons. We are honored to welcome Dr. Sekhar today and excited for his talk about bypasses and vascular reconstructions for complex intracranial aneurysm. And thank you for being with us today.
Good morning. I'm going to share the screen. Perfect. Can you see my screen?
Looks good.
Okay, perfect. Good morning, everyone. And thank you very much for the invitation. I am about 6 blocks down from where you are. So, all right. So today, my topic is, let's say, an unusual treatment for complex aneurysms in this day and age, but still relevant. I'll go to speak about bypasses and reconstruction. To talk a little bit briefly about the history of advances in bypass surgery, the first human STA-MCA bypass was performed by Professor Yazikil, and who had learned this skill from Donaghy and Jacobson, and the idea was suggested by C. Miller Fisher. Then saphenous vein high flow bypasses started initially by Luhid. Then Sant, Spencer, and others perfected this. Then we had radial artery grafts introduced, the EDAS technique, and then also intracranial to intracranial bypasses. The Alana technique, which is more or less fallen out of disfavor now, started in Europe. And a lot of things that go with the bypasses, particularly perioperative management, such as antiplatelet drugs, intravenous heparin during inclusion, burst suppression to protect the brain, induced hypertension, etc., and how to check the bypasses afterwards, and further evolution of these techniques. Now the indications for brain bypasses have diminished. Initially, it was very popular for brain ischemia. However, following the results of the COS trial and the previous trial, the STA-MCA bypass trial, then replicated in the COS trial, it's been mostly abandoned for ischemic symptoms, although there are still some cases which are non-responsive to medical management, non-Medicare age group, etc., and posterior circulation. It is still useful. Moya disease remains a major indication for bypass, particularly in adults, STA-MCA, in children, indirect bypass. And then for tumors, I don't show it here, but for some skull-based tumors which are involving the carotid artery in a severe fashion, patients have ischemia or require a carotid artery resection as part of the tumor operation. It's useful. It's quite unusual, these cases, but they exist. Now for aneurysms, complex ones particularly, bypass is still useful. Perhaps I would say in our practice, it is around 5% of the overall numbers of aneurysms treatment. Majority, of course, are being treated by endovascular techniques and clip repair. And these are some of the indications. Some are more absolute and some are relative. Examples are fusiform, very broad neck aneurysms, involvement of branches, dissecting aneurysms or blister aneurysms, patients who are at a very young age, and also recurrent aneurysms, where aneurysm has recurred after treatment with flow diversion stent, intraaneurysmal devices, surgical clipping, etc. And then also there are some complex aneurysms where you have a combination of bypass and endovascular treatment. And now when we talk about microsurgical treatment of complex aneurysms, I would say this is probably around 30%, maybe up to 40% in some places. Many of the complex aneurysms can be reconstructed by clip repair, clip reconstruction without the need for a bypass. Although in a number of cases, one should be prepared to perform a bypass because the clip reconstruction may not work, or you may lose a branch, either due to, mostly due to disease of the artery. And in some patients, we also may consider a preemptive high flow bypass to allow a longer occlusion time. There are, of course, a number of alternatives. The number one technique being the use of flow diversion stents. And for broad neck aneurysms, the use of intraaneurysmal device, particularly such as the web and contour. And then for ruptured large and complex aneurysms, one may consider initial coiling, subtotal coiling, and then later use of flow diversion. And some places may be using upfront flow diversion, although this makes it more difficult with the dual antiplate device. And then for dissecting and blister aneurysms, upfront flow diversion placement. Again, this is potentially has other complications, failure of treatment or by hemorrhages. And for distally placed aneurysms, endovascular occlusion or parent vessel sacrifice may be considered as well. So now when we do bypass surgery for aneurysms or complex aneurysms in general, we often will combine this with skull-based approaches. Skull-based approaches mainly give a better exposure of the aneurysm with more working space, less brain retraction, etc. It does add some time to the procedure, usually about an hour, especially for anterior circulation, which is where these are. For posterior circulation, this may add a little more time. And the approach itself may have potential complications, especially if one is inexperienced in using these techniques. This is one of the most common skull-based approaches, what we call the orbitopterional approach, where we combine a pterional craniotomy with full orbitotomy, and most of the cases, what we call a posterolateral orbitotomy. We just remove the back part of the orbit and then decompress the optic nerve and perform a clinoidectomy. This is a pretty common one we employ in our practice. Now, when we talk about bypasses, it's not, there are a variety of things we're talking about, mishmash of techniques. Broadly divided into local bypasses, which means that we're using one of the arteries in the vicinity. This is generally useful for small vessel replacement. And then you have extra intracranial bypass, where we are bringing in one of the extracranial vessels. The low flow may use the STA commonly, or occipital artery, and then the moderate and high flow will be using either radial artery or saphenous vein, and sometimes anterior tibial artery, etc. There are also hybrid techniques where you may use local and extracranial techniques, and also techniques which employ combination of bypass and endovascular treatment. So this is a compendium of cases that we put together here, and this is since 2005, over a 17-year period. The number of cases has declined somewhat over time, but still we keep doing them. For complex cases, there are a total of 207 aneurysms, most in the anterior circulation. And then, I see here, I'm trying to move this a little bit. Yeah. And the total bypasses were larger, of course, some of them having more than one. And ECIC bypass in 73%, and intra to intracranial about 27%. Of course, some of these were ruptured and some are unruptured. And this is the result, overall result, tallied at 3 months. MRS at 3 months, 11 patients or 5% died, 14% with a poor outcome, 81% with a good outcome. And the deaths, 1 patient related to the bypass, aneurysm related in 6, and other systemic causes in 4, 8% having strokes, which caused some disability. You can see the graft patency in the short term is 95%, long term 91%. Some of them develop spontaneous collaterals over time, so the bypass may occlude in time. The aneurysm occlusion rate was 96%. So now just speaking specifically about different locations, which is very important. For cavernous ICA aneurysms, for the most part, we are not using bypasses at all due to the inception of the flow diversion stent. However, there are very rare cases still where either flow diversion has failed, or a case like this where you have a severe stenosis at the entrance point and the exit point of the artery into the aneurysm. This is potential. This is one of the cases that was done maybe 2-3 years ago. And these are relatively good outcomes when it is done. But of course, most of the time they're not necessary at the moment. Now, supracavernous aneurysms, they still are a number of cases where bypasses are relevant. This is a case which we'll see later, but a case like this, the idea is, if you were to put a flow diversion stent, how do you use it, and how do you, which vessels are spared, and how do you build a construct, may be quite difficult. So bypass is a good alternative for a case like this. The main risk with the bypass for these cases is the anterior choroidal artery, because it may be difficult to preserve, and that can result in a stroke. Sometimes a fetal PCOM can also be problematic. MCA aneurysms, M1 segment, these of course involve the lenticulostriate vessels, and bypass is a good option for many of these people, particularly in younger patients. And and we'll see an example of this, because it allows you to place a bypass, and then you may be able to do a clip reconstruction in a way that the perforators are preserved. M2 segment, these are devoid of perforators. Sometimes you have complex aneurysms. This is, for example, a recurrent case where previous clipped, 2 vessels coming out, M1 going in, and then the question is, how do you reconstruct this by endovascular techniques? Not easy. You may have to end up sacrificing 1 vessel. So here, a bypass is a good alternative. In this case, a Y graft, Y bypass, or you may have to think about maybe endovascular flow placement with sacrifice of 1 vessel, which is not optimal. ACOM aneurysms, for the most part, are treated by either endovascular method or surgical clipping. However, there are complex cases, particularly large aneurysms with thrombosis, or previously treated cases, where this is an example of a previously treated coiled aneurysm, the coils have herniated into the parent vessel, and then the aneurysm has recurred. And in this case, I'll show you an example. We did an A3 to A3 side to side after clipping, because clip reconstruction was done, but immediately we lost the vessel because of coil herniation into the vessel itself. Vertebral pica aneurysms, and again, flow diversion is a consideration in a case like this, but you may, if you have a dominant pica, you may be concerned about losing that vessel. So in a case like this, a bypass with clip reconstruction can be an alternative in some of these patients. Basilar tip is the most difficult location. When you have a small aneurysm, meaning less than 1 centimeter, mostly they are treatable by endovascular techniques. But when you get to large and giant aneurysms, such as the one you see here, it becomes very difficult, even with the bypass, and I'll show you examples. The consideration here is a terminal basilar occlusion with a bypass if you don't have good PCOMs, or rarely clipping is also possible. But this area, this one remains very difficult. And lastly, the basilar trunk aneurysms. I understand my partner, Dr. Kim, said Dr. Spessler used to call this the glioblastoma of vascular surgery. These can be very difficult, mainly because of the involvement of a lot of perforators. Of course, a case like this definitely would be treatable by flow diversion and coiling through the other. But there are a number of cases of basilar trunk where there is progressive enlargement, thrombosis, etc. In the aneurysm becomes quite difficult. In the younger age group, meaning under 50, bypass with trapping is a potential option, and rarely we perform this in these folks where the aneurysm is growing and growing, and then they have a lot of thrombus, etc., strokes, and so forth. We saw this already. So now, during these procedures, anesthesia is very crucial. It's important to have a good team, not only anesthesia, but also nursing, an assistant, etc. We try to have balanced total intravenous anesthesia. The patients are given preoperative antiplatelet aid, usually aspirin. If they can't tolerate aspirin, we can give clopidogrel. We like to monitor SCPs and MEPs, and during temporary occlusion, in unruptured cases, we raise the blood pressure and achieve burst suppression. Ruptured cases, to keep it normal. And during the bypass, we give heparin, usually half the dose, not the full dose, about half dose. And this I've found it to be quite important. The technical aspects of bypass, the most common technique is the end to side method, where we are attaching one vessel to the side of the vessel, and end to end or side to side may also be used, especially for local bypass cases. Now, once the bypass is done, how do you manage the aneurysm is also crucial. In the anterior circulation, you may be able to clip the aneurysm even though there is a stenosis, just to preserve the perforators. Trapping is ideal, and in some cases, especially cavernous or preterite segment, you may elect only proximal occlusion, the distal vessel being still perfused by the ophthalmic, etc. Posterior circulation becomes more difficult choice. Trapping of or clipping of aneurysm is ideal. And fusiform basilar aneurysms, you may consider unilateral dominant vertebral artery occlusion. And for basilar tip, giant terminal basilar occlusion only, would be maybe considered in some patients. So I'll show you some examples where it makes it a little less abstract about what I'm talking about. This is a patient that I showed earlier. He's been previously coiled, and you can see that maybe the initial coiling should have employed a stent. The aneurysm comes off more on this A2. This is a dominant A1 on the left side. The aneurysm has recurred. So now the question is, where can you get a stent across this and push this inside and reconstruct it? Or can you do some type of flow diversion stent such as Fred, etc.? So this is a good case where we can think about a bypass option. Our initial thought was to just expose the aneurysm and clip reconstruct it in a way that the aneurysm is excluded and yet the artery is preserved. So a case like this, we need to have both A2s in view and of course A1 for the proximal control. So we employ a bifrontal approach with orbitotomy, and during surgery we dissect the olfactory bulbs. There's no traction, and then use a unilateral interhemispheric approach. And the aneurysm was dissected and clipped, but there was no flow in the vessel. So here is the, you can see the dural opening and unilateral interhemispheric approach, and the sagittal sinus is divided near the nasion, and then here we are exposing the A3, A4 vessels and tracing them down. And let's see, move forward here. So now we are looking at the aneurysm here. It looks pretty amenable to clip reconstruction, but what you don't see inside is the coils appear to be in the dome of the aneurysm, but they actually going in to the neck and the parent vessel itself, actually A2. So that's a temporary occlusion, and then perforating vessels in the back wall being dissected. So the aneurysm is fully dissected, and it looks very amenable to clip reconstruction. So we use one and then a second clip, and then making sure all vessels are separated, then using a second clip. And then the temporary clip is removed. We feel very happy, but the Doppler shows no flow in the left A2. So I tried to adjust the clip. Still no flow. So just the coils, which are herniated, were pinched or compressed by the clip. So that's the issue. So here what we do now is side to side using the contralateral A2. So now we give the patient intravenous heparin, 3,000 units. In this case, the patient is already on aspirin. So the technique is theoretically it's a little complex because you can't flip the wall. You have to suture from inside. But once you practice this in the lab a few times and you understand what you have to do, it's not so hard. Basically, so you have to make the initial stitch and then emerge the stitch on the inside, and then the back wall is sutured from the inside, as you see here. This is a, I believe, 9-0 suture. And then you leave the loops loose and tighten them. And then you emerge this stitch outside. As you can, that stitch has been brought out outside, and then you put an additional stitch and just tie it, as you see here, and then you put a series of interrupted, or what I call figure of 8 sutures. And here, after removal of the temporary clips, we have a good flow, and ICG angiogram showing a good flow here, and the postoperative angiogram shows good filling of the vessel all the way down to Hubner, which is an important vessel here, A2. And this patient with a good outcome. The short inner position graft, this is useful for intracranial cases, and also occasionally in a case like this. This is a child, and this is a patient who presented with sentinel bleed. She had double aneurysms, clearly some sort of developmental aneurysm involved in the entire M1 segment. You could see the one aneurysm and the other one, and there are 2 of them here. She was considered for flow diversion stent at the time due to her young age, and also the fact that there's a bifurcation point. It was not. It was rejected by the local interventionalist. So we operate on this young lady, and the main question is, where are the perforators? We just didn't see any, so presumably they were already occluded, or they're coming off of the distal vessels or more proximal vessels. So in this young patient, we ended up doing a radial artery replacement. This is orbitotomy has been done, so when fissure is being opened, and here's the aneurysm. That's one of the aneurysms. This is a proximal, and then this is there's a distal aneurysm here. So the aneurysm was dissected and resected, and so basically we have to do. Here's the other aneurysm, and in this patient, the anterior temporal branch had to be sacrificed. This is a more distal aneurysm, and this is the bifurcation point. You could see where the aneurysm ends at the bifurcation. So we had an ECIC bypass is more difficult in a young patient like this due to the size of the vessels and also the donor vessels. So ended up resecting everything, and then this is technically a little bit challenging. That's the radial artery being extracted, and then do the proximal anastomosis first. It's an end-to-end anastomosis. And then this is the distal anastomosis. So, and then the clips are released, and you could see here the radial artery is actually smaller than the MCA. And we extracted the radial artery from the forearm, so I didn't want to leave her -1 radial artery for the rest of her life, so I reconstructed the radial artery using a short saphenous vein graft. I didn't want to use a vein for the intracranial because I didn't know what was going to happen to the vein graft over a long period of time. And this young lady did very well. And over time, the radial artery looks no different from the intracranial vessel. You can see this is 8 years later. Occipital artery to pica anastomosis is the technique we can use or pica to pica anastomosis in some cases. This is a patient who had a mosaic of Marfan syndrome, and unilaterally, you can see one arm is longer and he had more problems. He already developed a carotid aneurysm when he was younger, and it was coil occluded. The artery was coil occluded. So he was already minus one artery. And then he came to us with this complex vertebral aneurysm. You can see our initial thought was to perform endovascular sacrifice of this one. The problem was that the pica itself is arising from the waist of this aneurysm. You can see here. This pica seemed to be a very large one. So we were reluctant to sac this vessel without some type of revascularization. So, and this is the contralateral side. You can see this is the dominant side here on this side. So what was done in this patient was exposure of the vertebral artery and the aneurysm, and then occipital artery was attached to pica, and then we just did a trapping. And this case, I won't show you a lot of details, but this is the occipital artery, rather the pica, and then attaching so that's the occipital artery to pica anastomosis. The occipital artery is not as good as the STA. In some patients, it can be quite unhealthy, in which case one can consider pica to pica anastomosis or a short graft from the area of the mastoid. So here's the occipital artery attachment, and then that's a bypass, and then just trapping the aneurysm. The aneurysm is trapped. So that. Now moving on to high flow bypasses. High flow, that by definition means more than 100 cc per minute. This is measured by post-operative duplex examination in our lab, a cerebrovascular lab. Moderate flow is 60 to 100 cc's per minute. The STA-MCA bypass, typically, even in the best circumstances, initially the flow is less than 50 cc's per minute, although as it matures, it may increase. So for acute replacement, when you have a larger vessel, you need a larger conduit, such as the radial arteries is preferred, saphenous vein, or less commonly the anterior tibial artery. And this is a more technically more difficult operation, even though the vessels are larger. So the main problem with the radial artery is that it can go into spasm. And years ago, I innovated this method called the pressure distension technique, where we flush out the vessel and then instill heparinized saline under pressure. You can visibly see that the spasm of the vessel relaxes, and then it doesn't go back into spasm. And of course, in all these patients, preoperatively, we check the size of the vessel. Should be at least 0.22 millimeters or more, preferably 0.25, and also make sure that they have a good collateral. So when this doesn't exist, then we go on to the saphenous vein or the anterior tibial. So that's called the Allen test. And here you can see how we are doing this pressure distension of the artery. And then we prepare the artery. And most of the time, I do the distal anastomosis first. As you see here, we create an oval arteriotomy and then fish mouth this vessel and Most of the time I use 8-0, sometimes 9-0 suture. So this is a larger vessel to a larger vessel, usually going to M2, rarely to P2, sometimes M3, but it's generally a larger vessel. So that part is easier, but there is more potential for problems because you are really creating a higher flow. So once this is done, we put a temporary clip on the artery itself, and the anastomotic time is usually under 30 minutes. And then we bring it to the neck and then attach it generally to the external, but if there are some collaterals, you can also go to the internal. Here's the external suture being done. So I mentioned that the saphenous vein is generally extracted from the thigh, but keep in mind that this is the proximal. We don't reverse the vein. So the proximal anastomosis is over here. The distal one is here. So the vein is, it enlarges a little bit. So there is a size discrepancy. Secondly, the wall of the vein is thicker than the artery. So there is a problem. And also the question, there are some issues about how the veins tolerate or what happens over time. So the anterior tibial is one that we have innovated in cases where we feel like the vein is not good or the radial artery is not good. This is generally harvested by our vascular surgeon, and it's most of the patients you can take it, and it's a very nice vessel to use. So some case examples. This is a patient, high flow bypass with clipping and trapping of multiple aneurysms. This is a patient who presented with sentinel bleed and severe headaches, has multiple aneurysms. She has a giant IC aneurysm. She has a large MCA bifurcation. And then she also has a basilar superior cerebellar aneurysm here. And of course, by this time, it's not clear which one had bled. We assumed that it was the carotid or the MCA. And so the plan was to clip the MCA and then try to see if we could clip this one, but with the idea that this may have to be trapped. So this is what we ended up doing. Clipped the MCA aneurysm. The aneurysm here was not fusiform, not clippable. So we did a bypass and trapped it. But it turns out that it was the basilar aneurysm that had ruptured or bled. So we simply excise the aneurysm and use this pathway to look at the basilar SC aneurysm and clip it. So that was the second day because it was still blood in that area. So we went back to clip that one. So here's the case in the left side, and left frontotemporal orbital approach, and here we see the M2 branches, and here's the middle cerebral artery bifurcation aneurysm, the broad neck, and here's the carotid aneurysm. And so the MC aneurysm is able to be clipped. And emptied. So, and then aneurysm is completely dissected and extra clip placed across the neck for the sake of security. Now, looking at the carotid aneurysm, it was apparent, and then here, optic nerve, clinoidectomy, and this is bleeding from the cavernous sinus. So it's obvious it's not clippable, so we extract the radial artery and then pressure distension, and here the bypass to an M2 branch. So we attach the terminal ends first, and then suture on either side, either wall. Usually I use what's called the figure of 8 suture, and then we bring it through a preauricular tunnel. And it turns out that the lower anastomosis is actually more important, technically easier, but more important because it's the inflow. And I did something here, but was not good, so we created a wide opening. We use a vascular punch, and then so good flow here, and then went and trapped it. But there's still blood in the basal. You can see how much blood there is in the pre-peduncular cistern. And so we went back and we excised this giant aneurysm. And you could see that the basilar superior, that was the smallest of the ones, and yet that was the one that had actually bled. Of course, we didn't know this initially, but so, and the patient had some vasospasm, needed treatment for vasospasm, but recovered completely from all these things. So this is the patient that I showed earlier, very complex case. This patient had been treated previously for a ruptured aneurysm with endovascular coiling. She recovered completely, but she had rheumatoid arthritis and was on pembrolizumab for arthritis with good remission. That may have had something to do with the development of the aneurysm, I'm not sure. But then she presented with this very complex and very bad looking aneurysm, and you could see that the ACA is coming out of here, and then the MCA, and the question is what to do. Now, in addition, she also has a basilar tip fusiform aneurysm. So this is the basilar tip sort of fusiform aneurysm. So and then she has something on the other side in the cervical area. So after discussions with our colleagues, we decided that the first initial treatment we to treat this carotid aneurysm, what was done was a bypass. And I tried to trap this aneurysm in a way that the choroidal could be preserved, but the choroidal was not flowing very well even at the initial site. So eventually I think the choroidal artery was clotted. So she had, and then we went back, you can see the anterocoroidal stroke, and but she recovered from that quite nicely. But we went back and placed 2 stents in this flow diversion stents in this
So
basal.
tell me how you're doing.
I'm doing really good.
Yeah? So what are you doing nowadays?
This is about 2 months after surgery, I think, maybe 6
Yeah.
weeks.
And getting stronger.
Yeah?
You can see that the left side is still
Your head?
weak. She's
Wow,
recovered
that's a big-
more or less
and,
completely.
I want to see you walk
Thin
through the
center.
door and then back. Yeah, that's okay. No problem.
A little slow.
See the
Yeah,
facial
I
weakness?
have,
So this is a late, this is a angiogram after about 4 or 5 months. You can see that the bypass is filling the MCA vessels pretty well. And then she has the basilar, was treated, and it's actually, and we stopped the arthritis medicine. I don't know whether it has something to do with that. So this is a young man with a NF1. He presented with left hemispheric stroke and hemiparesis. You can see this aneurysm involving the M1 segment. I showed you this case earlier. So in this case, we are able to, I was able to do the bypass and trap this one so that he had a good recovery. It seems like I'm missing that slide. I hit that slide. So let's see, it's a good one to show. But anyway, Another patient with M1 aneurysm, which was treated initially by flow diversion, and but there was a little leak. There are two stents. There's a little leak, and that started to grow, and then he developed a very big aneurysm, already presented with a stroke and hemiparesis. In this patient, pretty large, we ended up doing just an STA-MCA bypass and opened the aneurysm and found, actually saw that we could see the stent very nicely. The aneurysm was emptied, and he recovered, although he still had some expressive aphasia as a result of a stroke that he suffered earlier. Now the posterior circulation gets more complex, and the most difficult one being the basilar tip, and then again the size is the important. Size matters, and then the origin of this vessel. Now, a case like this, if you have a good PCOM, you could clearly think about going through the PCOM and putting a flow diversion, and with some coils, that would be a nice treatment for a case like this. So in this patient, we had a lot of discussion about possibly why stenting, etc. So none of that was selected. So we went in with the idea of creating a bypass, but as I got in there, the aneurysm started bleeding, actually perforated started bleeding a little bit. Then I started with the clipping, and I was able to sort of march the clip up, a technique which I call clip marching, clip walking technique. So put the clip and then dissect the aneurysm, and then keep moving the clip up and up until all the perforators are preserved. And this patient had a complete occlusion of the aneurysm. And there was a little residual filling, but it thrombosed off. This is a patient with giant basilar aneurysm, and we're still seeing some of these cases. Whatever the previous technique, stent coils, etc., there's a little leak, and the aneurysm keeps growing, and it becomes a mass lesion inside the brainstem. This patient presented with very bad shape, quadriplegic and so forth, and this big, and then you could see there are no PCOMs at all, and there are good 2 P2s and a lot of coil mass. So here our plan was just to do a terminal basilar occlusion, but because there are no PCOMs, we had to create an artificial PCOM. So this is done with the help of a saphenous vein graft, which is placed into P2 and then proximally into the V3. And then here is a petrosal approach. So this is a petrosal approach on the left side. You can see the sinus. This is actually done over 2 days because I don't want to do the approach and the bypass all on the same day. It just takes too long. So here is the subtemporal, and then here we see the potential site for occlusion of the basilar artery. This is the P2 segment, and with temporary occlusion, the petrosal approach really helps because you have more space rather than a simple subtemporal approach. And this anastomosis is technically more difficult simply because of the depth, not the suturing itself, but it's at greater depth. So the more the depth, the more difficulty, obviously. We're about 10 minutes. So, and then this is brought to the vertebral artery, and we create a nice opening using a vascular punch, and then suturing. And then here the terminal basilar occlusion is done below the SCA, just below the SCA. And now the bypass is opened, and you could see that. And this lady over time did very well. She still has a little remnant here of the neck, but it is not grown. So this is maybe considered as a bypass flow diversion. She recovered extremely well over time, and this is a late angiogram. So, one more. This is a young boy that I showed earlier, and I think that one today could consider flow diversion here and coil off this. He already had a couple of coilings, and the aneurysm grew. This was before flow diversion era, but he's also a pretty young man. And we ended up placing a bypass and a clip across, but there was still some leak into the aneurysm. So we went back and then coiled off this aneurysm at this stage. So this is a combination of bypass and endovascular techniques in this case. Now, just to show that we still have problems, especially with these posterior circulation aneurysms. This is a patient with a giant aneurysm. She's 3.5 centimeters, and a thalamic stroke. So there was no real option to treat by endovascular method. So we went, and he does have one PCOM, actually, not two. And the other one is very small. So we did a bypass, and to the terminal basilar occlusion, the aneurysm clotted off. But due to the mass, she deteriorated. But then she recovered over a few days. And but she's still some leak. And our thought was to bring her back and put some either a stent or stent coils. So that was her idea. She went to rehab. This is while she was still in the hospital. But about 3 months later, she had the acute onset of rupture or break of the aneurysm, and she died. So this was not, I think this is definitely still a problem area. We didn't solve this one. So instruments for bypass, each surgeon has to develop a set of instruments. These are very difficult to upkeep because they go to the central sterile area and they destroy them, or people don't take care of them, so they have to be perpetually maintained well. And we have sets, there are at least 3 of us that do these things, but so we try to keep these carefully. And then how do you train young people for bypass surgery? It's very important to go to the lab. During COVID, we also developed this thing called the home microsurgery lab. Dr. Abekasis and Dr. Sen work with me and Dr. Ellenbogen, and you can actually equip your home using a microscope, a stage, a small table, and you can practice on chicken wings. Then you have to work and, of course, learn by watching and then, working. And you have to progress first to STM, say bypass, and the high flow technique is more complex. So I would say that at least as of now, for the let's say less than 5% of the aneurysms that we see in our practice, these techniques are still quite useful, and you may think about it for some of your patients. Thank you very much. I'd be happy to answer any questions or entertain comments.
Thank you so much, Dr. Sekhar, for the great talk. I'll open the floor to our faculties for questions and comments.
Yeah, that was great. I always enjoy watching the videos. I think one of the really striking things is the creativity, and I think I expect for you that's a significant part of the joy you have in doing these cases. You can clearly see how satisfying it is to be able to come up with these solutions to incredibly complex problems. You know, the skill set is one thing, but the creativity is another component of it, don't you think?
Yeah, I think one thing I like to tell our residents is that, neurosurgery is a wonderful specialty because no matter where you are, functional neurosurgery, spine surgery, vascular surgery, tumor surgery, we have to first of all, the most important thing is to find a solution that is, at least if it's not curative, it's going to help them for a long time, but also creates a good outcome for the patient. But it's not one size fits all. It's not like cardiac bypass surgery where they have sort of gotten everything down to some very, well, not completely, but something more simple. In neurosurgery, we have still a lot of room for patient-centered and patient-oriented techniques and creativity. And I think that I have to say that whatever I am doing today will absolutely not the stuff that we'll be doing 20 years from now or even 10 years from now. The neurosurgery is in constant evolution. We are continuously evolving to whatever we may consider to be less invasive methods of treatment, etc. But on the other hand, we need to keep practicing some of these more invasive techniques, so we will have a bunch of patients that require some things. Yeah.
Stephen?
This is a great talk. Thanks again, Dr. Sekhar. I really enjoyed that. A couple of questions. One, intrasaccular flow diverters for these large basilar tips, especially some of the new Seal-It device and so forth coming forward that are up to 2 centimeters in size. Your opinion on those? And the second is intraoperative troubleshooting. If you've got sluggish flow or you do an ICG and things don't look great, what's your experience with salvage of the suture line or kind of intraoperative troubleshooting, massaging the vessel with forceps, papaverin, that sort of stuff for kind of salvaging a bypass that's not looking as good as you would like? Thanks. Right. Thank you, Dr. Martinez, for that. Intrasaccular flow diversion for these large angina aneurysms, I keep saying that that would be a good solution, but my endovascular colleagues keep pushing back. So they don't have the confidence that I have in these things. When you see these cases, you just want to have a good solution. The problem is we have a few of these cases where they were placed and we either lost the perforators or then the aneurysm kept growing. Nobody seems to have enough experience. We have quite a few cases where we place high porosity stents like Atlas or Neuroform and coils, but even some of those cases over time, the aneurysm kept growing slowly. But with the flow diversion, it seems to be more attractive for some of these cases, like the basilar tip that I showed, giant aneurysm. We don't yet have a nice flow diversion Y stent, like we have for the aortic stent, where they have a laser hole and then you put one stent through the other. But even in such cases, the concern is about the perforator. So I think that is something definitely perhaps needs further evolution and further thought and further innovation. Now, in terms of intraoperative troubleshooting, that's a very good question, very important. I think the number one thing I have seen is that there are two issues. There's always an issue of anticoagulation. So the patient, is not antiplatelet therapy, and is suddenly faced with something disastrous at surgery. So you know what to do, and then heparin is important, and then the wall itself. Some of these people, you go in and the vessel wall has atherosclerotic changes, etc. So now what to do? So in these cases, what I end up doing is actually to reopen the actual suture line and see what is the issue and see if we can reestablish flow. If not, go to a completely different, fresh site, that may be the only choice. And most of the time, the issue is bigger in smaller bypasses. Actually, the STMC bypass, if it drops or if it goes down, it's a bigger problem than with the higher flow, because you have a little larger vessel there. With the high flow bypasses, what we've seen is the proximal anastomosis is more important. You have to have a bigger orifice, so there's a nice inflow, and there shouldn't be any kinking of the vessel. So that's another thing that could be an issue. Once you get to that stage of actual thrombosis, especially with a smaller bypass, salvage becomes more difficult. The other thing that we have talked about in the past, and I've done this, shoot some integralin, or even in the past we even had TPA inside and so forth, but then the bleeding doesn't stop, so you just can't get it to clot anymore. So that's another issue. But again, that could be a consideration. Just to try intraoperatively put a catheter and then put something inside to see if you can, reopen that vessel.
Okay, thank you.
Thank you. Can I just ask one other question? With the one of the ACOM aneurysms you did earlier on in the discussion, you occluded the aneurysm and then you did the bypass. What's the occlusion time that you're comfortable with, or did you take the clips off the aneurysm and then do the bypass, or what?
Yeah, I think in that case, I'm pretty comfortable with 1 hour of occlusion maximum. In that case, occlusion time was probably, the aneurysm is clipped, and then I didn't get any flow, and ACA under hypertension, there is good backflow. There is backflow, so there is a distal flow. If you have a segment with perforators, then it becomes an issue. For instance, MCA, M1 segment, and so on. Definitely under conditions of induced hypertension, brain protection, in a segment free of perforators, 1 hour, less than 1 hour is pretty, but of course you want to get it down. The side-to-side anastomosis is fairly quick, actually, once you get started. That one that I showed there, it takes about 15 minutes, not very long. Of course, you need to have practiced it before, and then it's more of a geometric thinking of where the sutures are going. This is the more important thing in a case like this. And again, I emphasize the issue of having a good anesthesia and surgical team. You don't have an anesthesiologist who is familiar with this, and then your scrub nurse is not the one that you want, or whatever. I mean, these become very crucial in such case. I mean, you're operating on a patient at 6 or 7 in the evening or on a Sunday. It may not be the optimal thing for those cases.
Thank you. That's very helpful. I'm going to steal one more question. Aspirin allergy. You mentioned doing it on Plavix. I've had limited experience doing bypasses on Plavix, and live to regret it, including having to transfuse platelets just to proceed with the procedure. What's your kind of advice or take on aspirin allergy and performing these procedures on Plavix?
Yeah, I've had a few patients that haven't had any problems. I give them, I don't give them a loading dose. I sort of have them start taking Plavix gradually, like over 4 or 5 days. Unlike what we do with the endovascular technique where we load them, we just have them take it, and it doesn't seem to have any problem. I was concerned about it in a few patients, but nothing happened, nothing untoward happened.
Okay, thank you.
Thank you. Those are all very good questions.
Hard one, hard one lessons. really appreciate your time. We've kept you beyond what we asked, and we very much appreciate you being here this morning. Seeing the work of a master is always great fun. So again, thanks so much for sharing that with us, and for all the lessons you've taught us over the years. Thank you so much.
You know, I want to mention that Dr. Kim had this, and I think some of the others had these angio clubs that we have. I think we should revive that, so where we have some discussion with some of the patients. You know, I don't know, you guys, what your thoughts are, but I think it'd be useful sometimes to get together, and especially for young people, but even for older people like me, it's very useful. So.
No, those are always great. We had one maybe 3 or 4 months ago. I forget. Time goes quickly. We did have one.
I think so.
Post-COVID, but we need to do more. I absolutely agree. Thank you for bringing that up.
Yeah,
That'd be great.
Thanks very much. Have a great morning.
You too.
Thank you.